Good afternoon. Thank you, Mr. Chairman. It's my great honor to be here, and I'd like to thank to the organizing committee and the Professor Heki for inviting me to be here so that I can meet so many experts in the field of Ccsvi and give me an opportunity to share with some of our experiences in dealing with the venous problem in neurological disease. This afternoon, I would like to tell a little bit about the possible pathophysiology of cerebral venous outflow in the neurological disorders. Later, I would like to describe some neurological disorders according to the location and types of the venous abnormality. Finally, I will share with you some of our experiences or tell you what we have done or now we are doing in this field. The neurological disorders I'm going to talk is a little bit simple, not like Ccsvi in multiple sclerosis. The mechanism, possible mechanism, chiefly is due to venous ischemia caused by the transient hypoperfusion, caused by the retrograde venous hypertension through the incompetent jugular venous valve, or by exceeding high venous congestion or venous hypertension. Or it may be caused by we call venous artery reflex. That means a reflex, the artery would constrict in response to the venous block. Finally, the neurologic disorders may be related to the impairment of CSF drainage and absorption that will cause increase in the intracranial hypertension or ventricular dilatation. Now, I will describe the neurologic disorder according to the types and the location of the venous block. First, stenosis or occlusion of the intracranial outflow. The possible pathophysiology is impairment of the CSF absorption and the drainage. This includes three disorders. First, pseudotumor cerebri, or we call benign intracranial hypertension. Many studies have shown that this kind of patients are associated with sinus block or hypoplasia. This is a case report. Patient with headache and papilledema, his symptoms resolve after the stenting of this sinus block. And there are a lot of cases reports. There are venous sinus stenosis or block here, all cause intracranial hypertension. Then the neurologist also encountered the patient with venous sinus thrombosis. It usually involves the female fertile age, patient with headache or convulsion. You may see the venous infarction and the venous intracranial hematoma. The third, number three, is dural AV fistula. It is not uncommon to see a patient with dural AV fistula. 2 years before this, he may have sinus obstruction. We have a case, he developed dural AV fistula 2 years after surgical occlusion of the sigmoid sinus due to benign tumor involved that area. You can see the sinus block and dural fistula developed 2 years later. And we also find children have this kind of problem. The 2 years old children who have sinus thrombosis here, you cannot show the sinus, superficial sinus. At that time, there's arterial angiography did not show any AV fistula. 15 months later, the dural AV fistula developed. A similar case report in the literature, also in a child. After the thrombosis of superficial sinus with venous hematoma, venous infarction. At that time, the angiography did not show any AV problem. 3 months later, it developed AV fistula here. Now I would like to move forward to the neurologic disorder associated with the jugular venous reflux. The possible pathophysiology is transient hypoperfusion caused by the retrograde venous hypertension. There are many neurologic disorders are associated with this kind of problem. First, I'd like to talk about the transient global amnesia. Patient with global TGA, the clinical characteristic is he will keep repeatedly ask the same question. Where am I? Where it is? 1 minute after you tell him, he will ask it again because his inability to retain new information. Many years ago, we know there's jugular venous valve here, which can prevent the blood flow reflux. This is jugular venous flow, and this is vertebral venous flow. If patient have an incompetent valve, they will have the reflux of the jugular vein, which can facilitate the transmission of the intrathoracic pressure to the internal jugular vein, then to the cerebral venous system. Due to the fact patients with TGA also have the precipitative factor, such as the Valsalva-like maneuver before the attack. So that people think is the TGA related to the incompetence of the jugular venous valve. They did a study. That's true. In patients of TGA, have more than 70% have IGVVI, we call incompetence jugular venous valve, in comparison with the 35% in the control. In addition to the venous valve incompetence, we found our patient, more than 30% have we call spontaneous venous reflux, continuously reflux. The flow can only become normal during the deep inspiration. During the regular respiration, the flow is reflux to the brain. It can be illustrated by the tricks of a patient. You can see the contrast median to the subclavian vein. It will not go to the brachiocephalic vein. It goes direct to upward to the brain. There's a block in the brachiocephalic vein, completed block. The reflux in the TOF of the MRI, you can see to the sigmoid and the transverse sinus and to the inferior petrous sinus. It even can go upward to the cavernous sinus. If you do the sonography, you can demonstrate continuous venous reflux. Or you can see the reflux only in the upper part, or we call J3 area. But in the J1 or J2, you will see the smoke phenomena or spontaneous echo contrast. Be aware, there are two types of echo contrast. One is dense swirling. You can see the flow cannot move smoothly to the subclavian vein. This is associated with stenosis of the or occlusion of the brachiocephalic vein. Another one is like this. This most likely due to high level of fibrinogen, serum fibrinogen. Next, I would like to talk something about the emerging fugax. The textbook has told me transient monoarcular blindness has usually been attributed to the carotid occlusive disease, but in our population, only 15% of patients had extracranial carotid stenosis. So we think there must be another pathogenesis in this type of patient. We postulate ocular venous drainage impairment would be a plausible etiology. In our patient, we have seen many patients who have the venous reflux in the superior ophthalmic vein. The red column indicates flow outside to the extracranial. The blue indicates the flow into the intracranial. A patient, we have seen many of patients with this kind of the venous flow in the superior ophthalmic vein, and it simultaneously, you will find the to and flow direction in the jugular vein. You can see during the inspiration, the jugular vein is to the heart. During the expiration, is away from the heart. Also, the superior ophthalmic vein is also like this, to the intracranial and to the extracranial. It's simultaneously with the inspiration and expiration of the respiration. It's our experience the superior ophthalmic vein can serve as a collateral. In case of the intracranial hypertension, the flow would increase to the intracranial. It is normal in comparison with the normal. But in case of Ccsvi fistula, it can go out to the extracranial. And we also know there's some case report, emerging fugax would associate with Ccsvi fistula. So we make our hypothesis, the emerging fugax would be linked to the reflux of the jugular and the retrobulbar venous flow. And we test this hypothesis. There's significant difference between the patients and the control. 75% patients have reflux in the jugular vein and 23% in the control. More than half of the patients have the flow direction reversal in the superior ophthalmic vein, only 70% in the control. Later, we want to know if the reflux influence has the long-term effect of the venous system or arterial system. Dr. Jung, she's going to give a talk, the effect of the jugular venous reflux in aging. He has done the clinical study, and he has developed an animal model to see the effect of the venous reflux. She found that patient with emergency fissures had dilate retinal vein. You can see from this slide, patient, this is controlled, the diameter of the retinal vein. Patient with, particularly with the jugular venous reflux, have the wider retinal vein, both the left side and right side. We also have shown the patient without carotid stenosis have generalized increased vascular resistance in the retrobulbar artery. We check the PI-OI. PI-OI indicates the vascular resistance. In patient, the vascular resistance in the retrobulbar artery, both in the central retinal artery or posterior artery or ophthalmic artery, all the arteries have the higher vascular resistance than the control. Finally, we'd like to know, is there any CCSF component involved in this patient? We check the jugular venous condition at the C1 level, which is the most common lesion involved in the CCSVI. The C1 level, the venous compression at C1 level are grade into 0, minus stenosis, moderate compression, or severely compressed. You can see there's difference between the distribution of the compression in the patient and the control. If you consider grade 2, more than grade 2 is abnormal, then you can see more than 90% of control are normal, and more than half of the patients are abnormal at the C1 level. During the trick study, we also found, just like TGA, about 30% of patients have stenosis or occlusion of brachiocephalic vein with venous reflux to the brain. So we think our hypothesis have sufficient evidences. We found only 15% have carotid artery stenosis in those patients, higher frequency of the jugular venous reflux and the reflux in the ophthalmic vein. And we found dilated retinal vein and the increased vascular resistance in the retrobulbar arteries and the higher frequency of the venous outflow impairment compression at the C1 level. Now we have a question to ask. Why is there a racial difference between the Western and the Eastern society? We have 30% of our patients with TGA or TMB had venous block of the left brachiocephalic vein, but I found no such kind of blockage in the left brachiocephalic vein in the Western society. The second question I would like to ask, why the same condition, patients have the venous outflow blockage or valvular incompetence, has different clinical manifestation that it cannot explain, must be have a reason. Now move to the white matter change. Dr. Jones has nicely demonstrated the jugular venous reflux are associated with the white matter changes. I don't have time to talk all about other conditions. Have to move to another location, stenosis or occlusion of extracranial outflow. I skip this. In our country, we do not have many cases of multiple sclerosis, and also we do not, I have not seen a patient has stenosis or blockage of Ajax vein. But in our patient, we have jugular veins obstruction, compression at J2 or stenosis at the valve area, and we also have 30% of patients have blockage here. Now we have done 8 balloon angioplasty in our patient. 3 of them have complete blockage of the brachiocephalic vein. And this patient, only one patient whose symptom got improvement right after the angioplasty, so he is demanding we to do the stent placement. Finally, we accept to do this, and we put, you can see the reflux here, the block of the brachiocephalic vein. After the stenting, the reflux disappeared. Patient had been completely paraplegia for 2 years. After the angioplasty, he can move his legs, so he eagerly to have the stent placement. After the placement, 4 months later, now he can stand and walk with a walker. He's very, very happy. Last, I'd like to share some of our recent work. We call it dynamic stenosis or occlusion of extracranial outflow. I like to define this as cerebral venous outflow blocked during some hemodynamic challenge, such as deep inspiration, head-up tilt, or NTG straining maneuver. I would think this pathophysiology must be involved we call venous artery reflex. The clinical disorder include this. First, gravity-induced loss of consciousness. In pilot, they have to do acceleration and high G flying. In the training, they put the pilot here to centrifuge the pilot. Some pilot with loss of consciousness, some would not. They found the concave or collapsed jugular vein are associated with the loss of consciousness. The jugular vein is fully distended. The patient will remain his consciousness. So there's difference between presence or absence of the concave portion or venous reflux, and also the cross-sectional area. So the area become smaller, they are associated with the loss of consciousness. Then we found 2 interesting cases, pretty much like the gravity-induced loss of consciousness. It's panic disorder and also static intolerance. We have found some of these patients have a phenomenon when we doing the Valsalva maneuver and the head-up tilt test. We found they have impairment of autoregulations and they suggest cerebral vasospasm. You can see during the Valsalva maneuver, this patient normally, after the Valsalva maneuver, the artery would dilate and the resistance of the artery would decrease. But in this patient, it remained consistently higher. Even after the phase 4, it's still higher than normal. And during the head-up tilt, you can find patients' BP, blood pressure, do not change much, but the blood flow in the middle cerebral artery decrease can be more than 30%. We also found this patient, some of these patients have a jugular vein hyperreactive. During the baseline, you can see the jugular vein here. During deep inspiration, it almost totally collapsed. This is J1 portion of the jugular vein. And how about the J2? You can see the lumen remained, but the flow ceased, completely no flow. But if you test the flow here, the J1, it's increased. We checked the flow is coming from the collateral, the common facial vein. At that time, the MPA flow dropped. Just inspiration maneuver, the MPA flow dropped 15%. So we compared the patient with the control. We found half of the patient have this phenomenon, panic disorder. Half of them do not. You can, from this figure, you can see, if we arbitrarily define the lumen below, it almost collapses. You can see only patient have collapse of the jugular vein, and the flow cease also here. Almost, you can find that only in the patients. Some people would say the MCA drop is due to the hyperventilation during the head up tilt. But we found, indeed, there are some patients of panic disorder have hyperventilation. But in this case, in this group, patients with venous collapse, they do not have hyperventilation. Now, we also want to ask the question, why these patients have collapse of the jugular vein? Then, take-home messages. Now, we have more and more neurological disorders are linked to the venous outflow impairment. But the reason why similar venous outflow abnormality are associated with various neurological diseases remain unknown. We have to work up this. Can we consider all these clinical neurological disorders as Ccsvi without autoimmune problem, without iron deposit, without or you can consider this as a minor Ccsvi or early stage of Ccsvi? Let us think. The underlying pathophysiology of venous outflow causing neurological disorder needs further study, and the clinical cause and treatment of this venous abnormality needs further studies. Now, we found some of neurological disorder associated with venous outflow impairment. A lot of we need to dig it out. Thank you for your attention.
Thank you, Dr. Hu, for painting a broad brush where you've challenged us to a lot more areas than perhaps some of us realize may have been touched, certainly ones that I hadn't. Are there any comments from the audience or any reflection or ideas whether there is perhaps an East-West difference, or have you thoughts about some of the more exotic conditions as well, like anxiety disorders or panic? Please.
I only have a question. I understand that there have been observed psychological aspects of this, but I'm wondering, there are other reasons why a jugular can collapse, and people have rotational occlusions. So if somebody like sleeps with their head turned left and their left jugular is occluded, is it going to be important?
Yeah, I don't know why it would collapse during the inspiration. It's something like some people during supine position, the jugular vein would drain from the many blood flow drainage from the jugular vein. If the upright, you would.
There's the C1 and styloid. I mean, it just presses the jugular. Almost anybody, you turn their head.
Yeah, probably. Yeah. Also, we found not only this C1, also the brachiocephalic vein. If you lie on your left side, some people would cause compression of the brachiocephalic vein, would cause venous reflux to the brain. Okay.
Bill Code, University of British Columbia. I wanted to ask, I was lucky enough to go to the Space Center the other day, but there's an increased interest again in measuring intracranial pressure, and perhaps it'll turn into venous outflow, because many people, when they go into orbit, they get a huge filling of their head. They get a raised intracranial pressure, and I wonder if maybe they need the testing, not unlike you talked about for Thailand. Who is vulnerable? Maybe these are folks that would not make as safe a trip into space as the regular individual.
Yes, I believe. Thank you.
Thank you very much, Dr.
Thank you.
We're going to invite Dr. Zavadnov back up to talk to us about venous involvement in neurologic disorders.
Yeah, I have a text. So thank you very much. It's a great pleasure and honor to be here. And what I'm going to do is try to take a different approach. This has been an excellent, overview and introduction for what venous involvement can play in neurological disorders. So what I'm going to do these are my disclosures, just second. So what I'm going to do is I'm going to try through the Ccsvi go in a very similar direction, and hopefully by the end of the talk deal with a number of neurological disorders as well as aging. This slide can be really applied to a number of different diseases, and really what brought me to this type of research is that through highly specific MRI techniques, we can look for vascular pathogenesis in a number of neurologic disorders. And thanks to new MRI machines, especially high-field and ultra-high-field MRI, we are learning like never before how to assess vascular involvement in neurological disorders. Especially that's interesting for multiple sclerosis because of the perivenous association of MS lesions with SWI images, as you heard also before from Dr. Schelling. A couple of years ago, first images came from phase images from 7 Tesla, which showed very clear involvement of MS lesions in respect to the vein, which in about 80% of the lesions is central, as well around the lesions there is a high concentration of macrophages that are rich with iron. But this is not just the problem for MS. In MS we see the lesions. In other diseases we see iron deposition as well. And so clearly in Alzheimer, in Parkinson's disease, in multiple sclerosis, we see deposition of iron in certain structures of the brain, mostly in the basal ganglia. Nobody really knows why is that, but there is clearly a belief that exaggerated amount of iron is deposited in the areas where the most receptors for iron is, and these are the basal ganglia. However, even normal people deposit iron. This is a study of healthy people in 20 to 30, 30 to 40, and 50 to 60. And you can see that as you get older, you get more iron in the brain. But the fact is that in multiple sclerosis and in other diseases, we have more iron in certain structures of the brain. And these are not the same structures in Alzheimer's disease, in multiple sclerosis, or in Parkinson. So the question is really, what really regulates that iron, more iron builds up in the brain and builds up in different structures? So I will try now, through the Ccsvi, to build up this story. So first thing, what is Ccsvi? Thanks to Paolo Zamboni, I have been involved in this research, and it was quite a journey over the last 2.5, 3 years. And when he came to Buffalo with this idea, it was very compelling to find out first from his studies, then collaboration studies with Professor Zamboni, and then our independent studies, what Ccsvi is about. But as you can see from this image, it is about the strictures in the main outflow pathways, both in the jugular veins and in the azygous vein. Now, clearly, we are debating here, and we will be debating for a long time, how to do the best diagnosis of Ccsvi. Or, even if you want to call it differently, it's a question how we will call this number of findings we are finding on venous system in the jugulars and azygous respect to their characteristics. But I would say the safe approach is to take all what is available, and these are the techniques that are available from non-invasive and invasive point of view, and to start the research. And that's exactly what happened in these 3 years. So basically, the first criteria that have been established by Professor Zamboni, and as you heard, revised by the ISNVD Society on the last Congress. And they have been very elegant in being applied to so many subjects, whether they have MS or other neurologic disorders, or they are healthy people. So clearly, I'm not sure whether with other techniques it will be so easy to apply this criteria. And, but every criteria has pros and cons. And when you have yes, no, you have Ccsvi or you don't have Ccsvi, clearly the possibility for error is probably increased. That's why we came up with also severity score with Professor Zamboni a couple of years ago. Now, in our research, we kind of understood what Ccsvi is about, and I think this is in line what Professor Hu said. So clearly, all of us are finding these intraluminal abnormalities, whether they are at the level of the valve or they are close to the valve in forms of septum membranes, flaps, and webs. It's really a question of future studies to show. But these abnormalities are very highly represented in MS patients, but not only, because we are finding them in healthy controls and in patients with other neurologic diseases. The real question from dynamic point of view is what's happening with these abnormalities. Are they creating a turbulence? Is turbulence impairing the venous wall? And is the venous wall stenosing and becoming really what we see morphologically as a stenotic vein or fibrotic vein with annulus, or really, and what really the reflux and functional abnormalities play out. And I agree completely with previous speakers that the functional abnormalities may not be present constantly, will depend on the position. If you sleep, if you are in upright, what activity you are doing. So clearly, the dynamic process of creation of the collaterals as a compensatory mechanism for this number of intraluminal and extraluminal abnormalities is something to be determined. But I see clearly something happening from turbulence point of view in the veins, and then leading to functional, often on periods that are leading to compensation, and that's collaterals and probably in end stenosis of the veins themselves. That's why we are finding that much more progressive patients have this real stenosis, morphological stenosis, than non-progressive patients. Clearly, it's not my scope to go over diagnostic findings, and we see almost every week new paper. And I think that it will be very soon impossible to even show how many papers will be on this argument. But what I like to focus your attention on is that we need more papers with asterisks, and these are that are using more than one technique to prove that there is an abnormality or extracranial venous stenosis. And I'm not going to go through the disadvantages and advantages of these methods. This was our attempt recently in this review paper to define the advantages and disadvantages of Doppler sonography, magnetic resonance venography, as well as catheter venography for diagnosis of the Ccsvi. And each of them has pros and cons based on a position you are in, based on ability to define intraluminal, extraluminal, functional abnormalities, based on invasive or non-invasive approach, and based on clearly those things that you can control, like respiration, and that you cannot control in some exams, especially in the MRI. Also, there are mechanical issues where we are opening valves mechanically and clearly have problems in documenting possible anomalies. And I think this field is definitely going to improve, and we will, over years to come, become much more smart which techniques or combination of the techniques is the best. But we took an endeavor in the premise study to really do all 5 and find out whether they are overlapping always. And the answer is no, they do not. But this is a perfect case in which you see the same stenosis on 2D time of flight, tricks on the Doppler, on the CTV, on intraluminal ultrasound and catheter venography. And we would wish that all cases like are that, but they are not. And that's why this is the only way through the multimodal imaging and pathological approaches to understand what this condition is made of. And I think this presentation, hopefully, that Dr. Fox is going to elucidate us on in the tomorrow or after tomorrow, is a very important step forward to understand what really Ccsvi is about. And I think it's confirming findings from Doppler sonography that most of these problems are represented by intraluminal abnormalities. I think that the central part of my talk is really to understand and provide knowledge about what we learned about the pathogenesis of Ccsvi. So we know that there are known triggers of MS, infectious agents, Epstein-Barr virus being the most prominent, environmental factors, and genetic predisposition. In environmental factors, insufficiency of vitamin D, and in genetic factors, HLA-DR1501 are those most important that are leading to abnormal immunological response and possibly to MS. Now, the problem is that we don't know that these anomalies that I described, what are they really coming from? Are they congenital? Are they physiological? Are they aging related? We need to consider immobility also as one possible factor. Inflammation, are they virus related? Or really there are flow abnormalities at periphery and in the central nervous system that can influence appearance of these problems. So we believe that in MS and in other neurological disorders, venous reflux, and I would link to the previous talk, is possible trigger for endothelial damage, inflammatory pathways activation, and iron overload. But it's not happening equally in all neurologic diseases, and we need to understand why. We also agree that the perfusion damage and oxidative stress are possible consequences of reduced capillary bed blood flow, which might be due to CCSVI. We think that CCSVI definitely has a close connection to venous vasculature, and that cerebrospinal fluid flow also play a very important role. Finally, I think that CCSVI is connected with virus infections, and I will show some data in slides to come. So let's go through iron deposition. It's not clear for many years whether iron is primary or secondary in MS. May derive from myelin oligodendrocyte debris, destroyed macrophages, or can be product of hemorrhages. May be also related to oxidative stress and generation of toxic free radicals. Also, Professor Zamboni proposed that CCSVI related reflux, as I said before, may be a powerful chemotactic stimulus that attracts macrophages and contributes or causes initial activation of T-cell autoimmunity. There is a paper that we wrote an editorial recently from the group from Kansas City, and that's a quite interesting study published in BMC Neuroscience by Dr. Williams and others. In that study, they did two things. In a cerebral EAE model, they created inflammation artificially, and they measured iron load deposition outside or inside the areas of iron deposition. And they couldn't find iron without inflammation. They did a second experiment, and they measured by laser Doppler the blood flow in those inflammatory areas. And they found very high correlation between decreased blood flow and increased iron overload in these areas of inflammation. I think this is a suggesting model that iron could be very much related to inflammation. As a matter of fact, here on this meeting and on other meetings and in press, we have at least 3 or 4 papers that are showing that deposition of iron in a very early phase of clinically isolated syndrome patients, pediatric MS patients, is extremely related to amount of inflammation in patients with multiple sclerosis. That would probably lead to more inflammation being related to iron. But clearly, we know that patients with MS have perfusion damage, and that I think the most information beyond the classical MRI studies that have been done are coming from these anecdotal procedures, and probably when you are doing the procedure, you are increasing the blood flow through the cerebral capillary bed. That would probably increase the transfer of oxygen, glucose, and other nutrients into the brain, and can potentially reduce some of the MS symptoms like chronic fatigue and brain fog. I don't think it will likely substantially impact existing plaque and iron deposit, but also depends at which stage of the disease you are going to do it, and whether it can play a role in disease progression, and I will refer to that later. With Professor Zamboni, we did a study which looked on connection between the CCSVI and perfusion, and you can see almost 0.7 very strong correlations between reduced cerebral blood flow and increased CCSVI severity. We also published another paper recently in which found, with another technique measuring the venous vasculature visibility, very similar results. We also did with Professor Zamboni another study on cerebrospinal fluid flow and found that CSF flow is decreased in those who have more severity of the CCSVI. I think that these studies suggest that clearly hemodynamics of the brain is related to the CCSVI. But that leads me to another argument. If there is to some extent stasis in the brain, is that maybe a precondition to have MS? Or in this study where we looked healthy people, why these people did not develop multiple sclerosis? Do the combination of the things are necessary? So in this study of 252 healthy controls without non-CNS disease, prevalence of CCI was 28%. 34 subjects had history of infectious mononucleosis, of which 18 had CCSVI. The mechanism by which Epstein-Barr virus infection might trigger thrombosis really are not understood at the moment, but include transient elevations of antiphospholipid antibodies, which are extremely frequent in MS, and EBV-induced oxidative endothelial cell injury. Also, persistent EBV infection, which is the case in MS, in the small vein vessels, can directly promote pro-inflammatory, pro-coagulant, and pro-atherogenic environment. And whether EBV can damage endothelium, causing venous thrombosis and strictures in capillaries of the spinal and cranial veins is unknown at this time, but should be definitely studied. I wrote in this recent article the following sentence. The venous stasis hypothesis in the superior sagittal sinus may contribute to understanding why so many different viruses and bacteria have been linked to increased MS susceptibility risk over the last 50 years. We need to definitely study this problem. So I would change this slide and put CCSVI as probably one of the mechanisms in combination with others that lead to predisposition of higher susceptibility to MS, but in some others do not. So clearly, that leads me to the association studies of CCSVI with MS, normal aging, and other ONDs. Most of this information comes from the study we did in Buffalo called CTEVD, Combined Transcranial and Extracranial Venous Doppler Evaluation in MS. We did in all subjects Doppler, MRV, brain MRI with many different measures. We did the clinical examinations, took environmental information, took the blood for infectious agents, and genetics. So some of you may be familiar with this study. By using Doppler, we showed that 56% of MS patients, 22% of healthy controls, 38% of CIS, and 42% of other neurologic diseases had CCSVI. So based on this information, we concluded that CCSVI is not necessary nor sufficient for MS because many patients with MS have no CCSVI and many with CCSVI have MS, and some without CCSVI have also MS. However, there is definitely an association. So we went a step further and began to look, okay, is that association on a genetic basis? And as you can see here, when you look healthy people, it seems that the most relevant factor, risk factor for MS, which is DRB1, 1501, is actually higher in healthy controls than we found at CCSVI in the same healthy controls. And if you look, the MS patients, they were pretty similar, but progressive patients had more CCSVI than HLA DR1501. We looked a second thing, which is, do number and volume of the lesions and brain atrophy correlate with CCSVI? This paper entered in press a couple of days ago in American Journal of Neuroradiology. It's a paper of 350 subjects with MS and healthy controls, and we did not find connection between between presence of CCSVI and lesion volume and brain atrophy, although I have to say that there have been some trends. But power of the sample was big enough to conclude that there were no differences. However, we found that in pilot studies, and we are doing bigger studies, that CCSVI is connected with more iron deposition, with loss of vasculature visibility, with more hypoperfusion, and with decreased CSF flow. That leads me to clinical finding studies. In first study of 16 MS patients, no differences in disease duration, time for the first relapse, or type of disease was found between positive and negative MS. In another paper, no association with disability or secondary progressive MS has been found. Professor Bastianello showed on a largest MS study today that age at disease onset was about 5 years greater in CCSVI positive patients than those who were not. And the mini DSS score was 1 point higher in CCSVI patients, with more progressive patients having CCSVI. Our paper presented at ACTRIMS on 273 MS patients is just a days, I would say, before announcing it in press. And we found no association with presence and severity of CCSVI with disability. However, some subscores like brainstem have been associated. In logistic regression analysis, there were more CCSVI positivity in those with progressive MS. Clearly, over time, from these 499 subjects that I showed you, we built a lot of data, and now we are almost finalized with this study that contains more than 1,000 subjects in the relative groups. So what we know now from this study is A, that we are not finding correlation between CCSVI in controls without known CNS disease and aging. Although you can see that those who have one positive VH criteria, this is 2 positive, have a tendency for having more VH positive criteria with aging. Second thing, in these 252 healthy controls, we are finding that heart murmurus has an odds ratio of 4.9 for CCSVI. This is highly significant. So clearly heart disease, and I concur with the previous speaker, may increase the susceptibility for CCSVI. Very surprisingly, we also find that irritable bowel syndrome is increasing or is a consequence probably of the CCSVI. That's why I'm alluding and saying openly that we will need to begin study the disease that are not neurologic in order to determine whether CCSVI may be related to them. These are data under submission. I can't share these slides, but I will tell you briefly what we found. It's a study of 234 healthy controls and 78 ONDs. It's 3-to-1 age-and-sex matching. CCSVI was present in 70 healthy controls, 30%, and 42 ONDs, 54%. That's a P001. The distribution of CCSVI was 58.3 in neuromuscular group, extremely surprising to us, 56% in neuroautoimmune group, 53% in the neurodegenerative group, and 45% in the neurovascular group. Parkinson, MCI, myasthenia, migraine. We had probably over 35 to 40 different disease types in these 78 patients. So I would assume that it's pretty safe to say from this study that CCSVI is as much as present in other neurologic diseases as it is in MS patients, and is highly more prevalent than in healthy controls. Finally, I will spend my last 2 minutes on the treatment for CCSVI. I think that safety has to be established in not only short-term studies, but also in mid and long-term studies, because many of these patients who are undergoing treatment are getting more than 1, 2, 3, 4 And we need to understand what's the placement of the stents and repetitivity of the angioplasties produced in terms of safety. I would like to echo what has been said this morning by Dr. Burks in terms of efficacy studies. Efficacy has to be established in blinded, placebo-controlled phase 1 and phase 2 studies before we begin to design phase 3 studies. With 3 types of outcomes. Disease modifying, in which we will look MRI, and that means lesions, brain atrophy, and others. I agree, let's look perfusion and iron and others. Clinical disability with EDSS and relapses in terms of annual relapse rate, time to first relapse. Then we need to look quality of life, and as Dr. Burke said, there are very well established instruments for doing that. SF36, one of them, but there are many others. Symptom management, fatigue, headache, brain fog, sleep disturbances, autonomic control, cognition balance, these are all that have been, through the reports and our own observations, linked to CCSVI treatments. We need to understand the value of open label studies, what we can learn from them. I think we can learn a lot, but they are not going to be an answer for what it's going to clearly, they are going just to be a mean, intermediate mean to take us to the next step. And we need to understand the risk versus benefit before we can recommend this treatment on a large basis. Our first step was to do the prospective randomized endovascular therapy study. It's a very small pilot 1 study with 30 patients. We are almost done with it, and as you can see, everything has been applied in this study, what I showed in the last slide, from quality of life to symptom management to MRIs to disability to relapses. So we will know soon. So my last slide is something that I presented yesterday. Does CCSVI exist? I think it does. Whether we call it CCSVI, jugular reflux, or something else, it's a matter of debate to be debated over the years to come. It's not unique to multiple sclerosis. It's subject also to other neurologic and non-neurologic diseases possibly, and also in healthy people, and we need to understand why healthy people do have CCSVI and do not develop, and that has to do with other factors. What CCSVI represent? That's another question. We are going better to understand the clinical signs of the CCSVI, especially thanks to treatment. We need to agree what are the base non-invasive or invasive tools and combination of these tools, and clearly multimodal approach is mandatory. I think that hundreds of association studies needs to be done in order to understand how venous system interplays with environmental, viral, genetic, and immunologic factors. And finally, we need to continue to promote safe approaches for understanding the value of this treatment. And I think that's, as for a couple of more days president of this society, I would like to encourage everybody to come together and try to organize trials that are ethical, they are well designed, and that can answer some important questions. Thank you very much.
Thank you for that outstanding perspective. And I'll take a moment as a mantle as the editor-in-chief of the Journal of Vascular Interventional Radiology to applaud you and leading researchers here for having built such an enormous base of evidence on the neurologic and the imaging side. And yet the quandary, as you illustrate, is we have tens of thousands of patients who have been treated by a whole variety of things, and we have such a tiny literature on that side. There's a huge missing gap, even in short-term safety in large numbers, with people who have experience in the hundreds and hundreds, and yet we don't even have a real base of 30-day safety results. That alone is a question in people's minds, and it's a huge opportunity to present those papers and to publish. The literature needs the same type of demonstration of replicability that you're achieving with this type of research. And that gap is, I think, going to move what is commerce and treatment together into method and validation. And that has to happen. It's a great scholarly opportunity for people in this room and beyond.
Thank you very much.
Any quick comments from the audience before we move on? I know we're behind, but this material is just extraordinary. If not, the speakers will naturally be available afterwards. Let's move back into the realm of basic science and invite Dr. Cook up to talk to us about hemodynamics, the effect of them on endothelial adhesion and permeability. Welcome. Maybe you go to Mike? Yeah.
Thank you, Dr. Haskell. I think this is... Yeah. Well, thanks, Dr. Haskell. And I want to thank the organizers, Drs. Vadanov and Heikki and Dake, for inviting me. I'm very pleased to be here and to hear all of the interesting new information on CCSVI. I'm at Stanford. I'm at the cardiovascular. I'm in cardiovascular medicine in the institute there. My interest over the past 25 years has been the endothelium, and today I'm going to talk about how alterations in endothelium permeability and adhesion may be playing a role in CCSVI. I do want to mention this paper that's coming out. Mike Dick and I put this together. It was a retrospective review of 40 cases that he treated at Stanford of CCSVI. These individuals were treated with self-expanding stents and with marked resolution of the venous stenosis, and then in retrospective follow-up of these patients, an improvement in their symptoms that persisted for a year. Of note, there were 2 patients that had serious complications. One patient had a migrating stent that needed to be removed by atriotomy. The patient subsequently did well. One patient had, about 9 weeks after the procedure, had an intracerebral hemorrhage after Coumadin. The patient was placed on Coumadin, and she unfortunately died. So this, although the results of the study were intriguing, it certainly needs to be, now we need a double-blind randomized clinical trial. However, as a vascular biologist, I'm struck by the effect that these venous stenoses and reflux that we've been hearing about at the meeting the impact that would have on the endothelium. It's something that I've been studying for 25 years. And the case I'm going to make to you today is that the altered cerebrovenous hemodynamics that we've been hearing about at this meeting could certainly predispose to MS pathobiology. And I'm going to, in particular, increased strain, cyclic strain, which is stretch of the vascular smooth muscle with increases in pressure, and low shear stress on the endothelium may predispose to adhesion, molecule expression, chemokine molecule expression, smooth muscle cell proliferation, and extracellular matrix elaboration, resulting in the MS pathobiology that's observed by the at autopsy. Brought to our attention by Dr. Zamboni was the similarity between venous insufficiency in the periphery and venous insufficiency in the brain. Now, what you're looking at on the left is a microphotograph from his paper in 2006 showing you what the microvasculature of the small venules look like in an individual with chronic venous insufficiency of the lower extremities with the thickened vessel wall, vein wall, and paravenular cuffing. That same kind of pathology is observed in the venules of patients with multiple sclerosis, this thickening of the vessel wall and paravenular cuffing. Also, we've heard about the egress of red blood cells into these vessels, which are more permeable, and hemosiderin deposition has been observed both in chronic venous insufficiency of the lower extremities and in the brain parenchyma. As I mentioned, my interest is the endothelium, and I've been studying it for 25 years, first at Mayo Clinic and Harvard, now Stanford. And what I've learned is that the endothelium plays a very important role in maintaining vascular homeostasis. It regulates vessel tone, growth, and interaction with circulating blood elements because of the paracrine factors that it produces. It's a virtual factory of paracrine factors, and the one that I've been particularly interested in is nitric oxide. But others, endothelial factors, can maintain vascular homeostasis. When the production of those factors is perturbed, you see increased inflammation, smooth muscle cell proliferation, and thrombosis. So I'm going to talk about the major biomechanical forces impinging upon vascular cells and how those may be disturbed in CCSVI. That has not been the subject of my study, that particular disease entity, but it's been other disturbances of blood flow, such as those observed in atherosclerosis. But the general biology is, I think, is similar. So the endothelial cells are exposed to blood flow, which exerts a tractive force of shear stress on the endothelial cells. So that fluid flow exerts this tractive force on the endothelial cells, and that can be sensed. The vascular smooth muscle cells primarily are not exposed to the shear stress, but exposed to the cyclic strain of the pulsatile pressure. So as the pressure increases in a vessel, the vascular smooth muscle cells are subjected to some cyclic strain. Both of those are perturbed, I believe, in CCSVI. The effect of flow on the blood vessel, laminar shear stress, physiological shear stress, has beneficial properties, actually. As you increase blood flow in a straight segment of the vasculature, you have a laminar shear stress, which causes the release of nitric oxide and prostacyclin and causes this vasodilation. You're looking at a microphotograph of a rabid iliac artery at rest with no flow, and then with 2 mLs per minute, which is the maximal flow through that iliac artery in the animal. And that causes a nice flow-dependent vasodilation. You can see the same thing in human vessels. When you remove the endothelium, that flow-mediated vasodilation is lost. Now, the effect of flow on the vessel also has long-term an effect on vascular structure. And what you're seeing here is a right renal artery that's normal, and with a normal right nephrogram. But on the left, if you look at the arrow, you're looking at the left renal artery there that's supplying a small and atrophic kidney. The blood flow to that kidney is reduced, that atrophic kidney, and as a consequence, the left renal artery has remodeled over time. So it's much smaller than the right renal artery. That phenomenon of flow-mediated remodeling, negative remodeling, or positive remodeling with increases in flow, that remodeling is also dependent upon the endothelium. Lowell and Gill showed about 15 years ago that if you remove the endothelium, you can no longer get that kind of remodeling in response to changes in blood flow. So the vasculature responds to blood flow, changes in blood flow acutely with flow-mediated vasodilation, and it can respond to changes in blood flow chronically with negative or positive remodeling. How does the endothelial cell sense force? It's still somewhat controversial, but the tensegrity model has is the current paradigm. Basically, as the endothelial cell is exposed to this shear stress, attractive force of fluid flow, it is deformed. And this force is transmitted throughout the cell to the nucleus, in fact. And you can actually see the nucleus remodeling over time in response to laminar shear stress. It will line up in the direction of shear stress, as will the endothelial cell. So the cytoskeleton is the sensor of the shear stress, with the endothelial cell tied at its basement membrane to focal adhesion sites and also to the nuclear membrane and the plasma lemma. We've looked at flow in a number of different ways. You can maintain laminar shear stress over cells using a cone plate viscometer or a parallel plate chamber. And what you can see over just the course of 24 hours, you can see the endothelial cells lining up with that laminar flow. And that phenomenon is fairly dramatic, as you can see on the right-hand side there. That's actually after 24 hours of flow, you can see this nice rearrangement of the endothelial cells. Their biology is altered too. So in a straight segment of a vessel or in these laminar flow fields, the endothelial cell is healthy. It's making a lot of nitric oxide and prostacyclin, and that downregulates adhesion molecules and chemokine expression. Well, this vascular inflammation is mediated by adhesion molecules expressed by the endothelium, and the entry of an inflammatory cell into a tissue really depends upon the endothelial expression of these adhesion molecules and chemokines. The expression of these adhesion molecules and chemokines is increased with disturbed flow, and I'll be showing that to you in a moment. But just again show the effects of physiological shear stress. Normal shear stress reduces the adhesiveness of the endothelium and makes it more like Teflon. In this study, I should go back, we exposed the endothelial cells to a shear stress, a laminar shear stress, or not. They were just cultured. And then we tested their adhesiveness to monocytes in this functional binding assay. We took monocytes, we labeled them with fluorophores so we could see them. And then we just let them incubate with the endothelial cells, and then we washed the non-adherent cells off and just simply counted the adherent cells. And the number of cells is reduced by flow. So static is in the open column there. The second column you see are the monocyte adherents with flow. And you can see that endothelial cells exposed to flow. So the cells are not adhering in a flow field. They're adhering with the cells quiescent in a dish. The cells were pre-treated with flow. So pre-treatment with flow reduces endothelial adhesiveness. And by contrast, endothelial cells in a disturbed flow field have an altered biology. They become more adhesive. They become a little bit more like Velcro. So when we do these experiments with altered flow fields, the endothelial adhesiveness is increased, the expression of adhesion molecules and chemokines is increased, and that has been demonstrated at bends, branches, and bifurcations of blood vessels as well. At these sites, you have recirculation of blood flow. You have eddies. So you have at these eddies, you have recirculation, you have reversed or low shear stress in these areas, and that's experienced as an abnormality by the endothelial cells. Endothelial cells are no longer aligned. They look more like cobblestone paving, and their biology is altered. I'll show you that in a moment. So to summarize the work that's been done in this field by our group and others, in a laminar flow field where you have normal shear stress, you have vasodilatation, you have the release of vasodilatory factors and hyperpolarizing current, and the vessel relaxes. Also you have reduced adhesion, reduced expression of adhesion molecules and chemokines. You have reduced vascular smooth muscle cell activation. These same factors that are causing vasodilation also suppress the proliferation of smooth muscle cells. So you have in these laminar shear stress areas, you have basically vascular homeostasis. But it's at bends, branches, and bifurcations where you have disturbed flow that the biology of the vessel starts to change. And I think this process is occurring in Ccsvi. In these areas where you have disturbed flow, you're making less of the vasodilatory factors, you're making more of the adhesion molecules and chemokines, and smooth muscle cells are activated, proliferating, and you have an increase in wall thickness, you have an increase in inflammation in those areas. That's why in our patients in cardiovascular medicine, we tend to see lesions occurring in the coronary arteries at branches and bends. You see this in the carotids as well. You see at the carotid bulb or at other bends and branches, you see this kind of, you see lesions forming. What you're looking at here is a human vessel. You're looking at a branch. You see the first grossly visible lesion of atherosclerosis. These are the fatty streaks that occur very early on in Western cultures. You can see this in teenagers, these fatty streaks occurring. So these are the precursors of atherosclerotic lesions. They occur at these very same sites where the endothelial function is disturbed. So what comes before the lesions, of course, is this abnormal endothelial biology that I've been telling you about. So The endothelial biology matters. The response to disturbed flow leads to lesion development. And what you can see in these branches, if you look at the endothelial cells, is that the endothelial cell morphology is altered too. So endothelial cells in a straight segment, up above panel, you are nicely aligned. This is a silver staining of a straight segment of a vessel. You can see the endothelial cells are nicely lined up. At a branch, they look more like cobblestone paving. They're no longer aligned. They're morphologically different. Their biology is different. In the lower right-hand panel there, you can see at a much higher magnification, scanning EM of endothelial cells that are where the biology is disturbed. And you can see something very abnormal. You see not only these polygonal endothelial cells, but you also see platelets adhering to the endothelium. That's very abnormal, because normally the endothelium, when functioning normally, releases nitric oxide to inhibit platelet aggregation. Now there's another vascular pathobiology that's quite controversial, other than Ccsvi. This is the pathology induced by a myocardial bridge. So there's a growing evidence in the cardiovascular literature that this impairment, this vascular impingement, can also lead to pathology. So what is a myocardial bridge? It's, what you're looking at is myocardial fibers that are crossing over an epicardial coronary artery. This is the left anterior descending coronary artery in a 70-year-old patient that died not of a myocardial infarction, but this individual was found to have a myocardial bridge. This pathology is being seen with increasing frequency or recognition now in patients with atypical chest pain. It has some interesting effects on the underlying endothelium. So when the heart contracts, this muscular bridge contracts, compressing the coronary artery. And there's evidence that it can cause angina with increased workload. In the next couple of slides, I'm going to show you the pathology at 3 different sites. A is proximal LAD, B is over the bridge, and C is the distal coronary artery. Now, if you were to look at the flow patterns in this coronary artery, you would see proximally and distally disturbed flow. The endothelial cells in the bridge actually are exposed to fairly laminar shear stress, actually a higher velocity shear stress than the rest of the vessel. It's really more downstream and more upstream of that area where you have the disturbed flow. And what's interesting is that's exactly where you see the endothelial pathobiology. So again, on the far right-hand side are the endothelial cells that are proximal to the bridge, and they have this cobblestone patterning. So right in the area where you'd expect disturbed flow, the endothelial cells have this cobblestone pattern. Within the bridge, they're actually nicely aligned. Those endothelial cells should be exposed to actually higher velocity shear stress that's laminar. And then distal to the bridge, you have, again, this kind of more of a cobblestone pattern. It's somewhat intermediate between A and B. What's interesting about this myocardial bridge phenomenon is that the lesions that occur in these patients, the atherosclerotic lesions, tend to occur proximally or distally, and the bridge, the vascular segment in the bridge is actually protected from atherosclerosis. So it's a little bit opposite of what you might think. But the endothelial cells in that bridge that's exposed to higher shear stress, laminar shear stress, are actually making more nitric oxide and are protected from atherosclerosis. This is what you see in terms of atherosclerosis. A, again, at the far right, is the vessel thickness in the proximal segment. And what you're looking at, that arrow is basically showing you the thickness from the internal elastic lamina, shown by the arrowheads, and the endothelial surface. So that's the vessel wall thickness. By contrast, if you look at B, there in the middle, the thickness of the intima is much less, and then C is somewhat intermediate. So in that proximal area where you have disturbed flow, you have recirculation, you have abnormal endothelial cells, and you have increased vascular smooth muscle cell growth. You have a plaque forming in that area. So it just is another disease entity that where alteration in flow can lead to significant vascular pathobiology. To summarize about 20 years of work from our group and others, low shear stress, disturbed flow, is associated with a number of pathobiological alterations, including a reduction in nitric oxide production and loss of the usual homeostatic mechanisms. And you have increased oxidative stress, you have increased adhesion molecule expression, and you have a tendency for lesions to form in these areas that are exposed to low shear stress or recirculatory flow. Now, I do want to just mention, in getting close to my final remarks, that cyclic strain also is very important. So this is the effect of pressure on the vascular smooth muscles. So the vascular smooth muscle cell is not exposed to the tractive force of fluid flow, but it is exposed to strain, the strain of the changing pressure in the lumen of the vessel. What that does, increasing strain beyond the physiological level is in the range of 6 to 8% in the arterial circulation. It's much less in the venous circulation. When you have an increase in pressure, vascular smooth muscle cells exposed to that increase in cyclic strain proliferate, and that's been shown by a number of authors. This paper just came out fairly recently. I thought it was pretty interesting because there are stem cells in the vascular wall that are thought to play a role in myointimal hyperplasia, thickening of the vessel wall. What these authors showed is that MSCs, these mesenchymal stem cells, and when exposed to cyclic stretch in the apparatus shown above, when exposed to cyclic stretch, will actually proliferate. That's shown in the right-hand panel, the cell count increasing with increasing strain. So the cells are proliferating. But they're also transforming into vascular smooth muscle cells. So these stem cells that may be found in the vessel wall transform into vascular smooth muscle cells and proliferate. And, of course, this is what we see in areas that are exposed to the increased cyclic strain. And these areas are at bends, branches, of bifurcations, or in the case of Ccsvi, I think they're upstream of the stenosis. A is just showing you the smooth muscle, expression of alpha smooth muscle actin in these cells. So they're transforming into vascular smooth muscle cells and proliferating. Some work from Nicholson at Yale, who's building blood vessels. So she's very interested in bioengineering blood vessels. What she's done is to take vascular smooth muscle cells and incubate them in tubes of polyglycolic acid. Now, what she's after here is to try to make a vessel that will maintain its hoop strength, and you can plug that into a circulation, use this for a bypass. So she's trying to make bioengineered blood vessels. And what she's done here, I think is quite interesting, is to expose these tubes. So this is just vascular smooth muscle cell in a matrix, an artificial matrix, polyglycolic acid. She's exposed these tubes to changes in cyclic strain by perfusing them with fluid, with media, and increasing the amount of the number of pulses of the fluid as it's going through the vessel. And what she shows you in A, B, and C are tubes that have been exposed to increasing cyclic strain. And you can see in A, B, and C, those are H&E stains. There's increasing vessel wall thickness, largely due to the fact, as you can see in D, E, and F, that these vascular smooth muscle cells are making a lot of extracellular matrix. That's a trichrome stain, mastodon trichrome stain, which shows collagen in blue and glycosaminoglycans in green, and pink is cell bodies. And what you see is a spectacular increase in the expression of extracellular matrix. So this is another thing that happens with increases in cyclic strain. The vascular smooth muscle cells proliferate, and they make extracellular matrix. Something of interest, we're also bioengineering blood vessels in my laboratory, and we've been trying to get endothelial cells to behave properly in our bioengineered vessels. And Nan Wong, who's a bioengineer working with me, she's from MIT, has shown very nicely now that endothelial cells not only will respond to the tractive force of fluid flow, but they also respond to the matrix that they're sitting on. And if you take random collagen, just coat your dish with that, the cells line up randomly. But if the collagen is aligned, as shown in the bottom left-hand panel, this is a line collagen, it's nano-patterned collagen with fibers that are 30 nanometers in diameter, and they're lined up nicely. The endothelial cells will line up nicely, as you can see in this phalloidin stain. The endothelial cells line up nicely, and they behave like normal, healthy endothelial cells. Here's one piece of data. What you're looking at is fluorescently labeled monocytes that have been allowed to adhere to the endothelial cells. And then you can see on the left that with non-aligned endothelium, you can't see the endothelial cells in this case, you're just seeing the monocytes. But the non-aligned endothelium is much more adhesive than the aligned endothelial cells. So the alignment of endothelial cells, their biology matters because it does regulate the adhesive interaction with circulating inflammatory cells. So you can imagine this is my final slide, you can imagine in the setting of CCSVI, where you have disturbed flow, where you have reflux, where you have increases in pressure because of the stenosis, you're going to have increased strain acting on the venular vascular smooth muscle. You're going to have low shear stress or reverse shear stress acting on the endothelial cells. And wherever that's occurring in the cerebral venules, you're going to have a response to that by the endothelium and the vascular smooth muscle. The expression of adhesion molecules, chemokines, increased permeability, smooth muscle cell proliferation, extracellular matrix elaboration, that reinforce the MS pathobiology. I agree with Dr. Zavadinov that it's a combination of forces that are acting here. You have the hemodynamic forces maybe acting or acting on some other endogenous or extra environmental factors, but you end up with this MS pathobiology that we've seen in the peripheral vasculature, see the same kind of thing in the cerebrovenous vasculature, and I believe the underlying hemodynamic mechanisms and the biological response are similar. So this is the group that's helping me do the studies. Thank you for your attention.
Excellent presentation. How this apply to the diameter of the vessel, let's say to the capillaries versus, jugular vein? I mean, the shear stress. Can you elaborate on that?
No, it's a very good question. I've been thinking about that myself. Certainly, I think in the larger venous conduits, the alterations in flow and pressure that are likely occurring in CCSVI, those forces are certainly acting on the larger conduits that are upstream of the stenosis or the reflux. I think what you're asking is what about at the microvascular level? Are these same phenomena occurring at the microvascular level? I don't know. I think we need animal models. We need more work in humans to understand that. I suspect that there are similar alterations occurring, and I suspect it from the pathobiology that we've been shown by at autopsy in our MS patients, that the paravenular abnormalities and venular wall abnormalities that we observe suggest, those similarities suggest that the same processes are occurring that occur in the peripheral venous insufficiency at the microvascular level. So I think the answer is not in, but it's a hypothesis at this point that the same thing is happening at the microvasculature.
I mean, might it be that it's much more prone in the microvascular circulation in this population? Because, I mean, do we absolutely know that jugular veins in patients who are treating adjacent to presumed vascular stenosis demonstrate these areas of proliferation and thick walls? I mean, we've looked at a lot with ultrasound. We have some collective wisdom in the group. Have we really convinced ourselves that there are abnormal endothelia in larger jugular veins near these stenoses? Or maybe it is all or largely microvascular?
Mm-hmm. No, it's a really good question, and it really needs further study.
Thank you for a very excellent lecture. Since you have all these elegant in vitro systems, you have endothelial cells and monocytes, I would like to remember all data from James Kirkpatrick from Germany showing that titanium dioxide, which is a pigment used on the pills of any hypertensive drug or Parkinson drugs and so on, will activate endothelial wall. So it could be very interesting to add this to monocytes, and I will tomorrow present pictures of macrophages which are completely full of this titanium, and see if you get activation or hyperactivation of the endothelium, because it's of course have a clinical relevance. So maybe the reason for different frequencies of stenosis and restenosis may be simply very trivial, that different patients are taking different drugs and their reticuloendothelial system is basically overloaded with endothelium activating substances through their pills.
No, thanks for bringing that up, because I think the disease is multifactorial. I agree with you, and Dr. Zvadnov said that earlier.
I think you can take it a lot further. We're treating, some of the more immediate implications that really come to mind are on the therapeutic side, because what we're doing is we're, in an atherosclerotic model, we're essentially creating a two-layer tear and invoking a healing response to larger diameter. Here, we're activating that endothelium. The same elements aren't there. There isn't an atheroma. And we're treating the therapy as if it's sort of a monotherapy. We all stretch it to the same degree. We all create the same degree of endothelial injury. And yet, probably much of the disturbed forces are even more applicable at that large vessel after we stretch something, or at the edge of a stent where we have a disturbed turbulent zone and that kind of classic head stenosis that develops. It almost seems like we should, the post-angioplastic, the degree of injury that we're doing perhaps in animal models should be correlated with minimizing endothelial activation or response.
Oh, that's a very good point. I mean, the more you stretch the vascular smooth muscle, the greater injury occurs, and you may actually increase your risk of restenosis of myointimal hyperplasia. That's a very good point.
How long do you think it takes to re-endothelialize a large vessel like this that has had a stent implanted or a long segment injury by a balloon?
Yeah, that's a very good question, and it depends upon what you're looking at. If you're looking at in animal models, it's of course different. Mice are very good about re-endothelialization, but humans not so much. So there's actually some data from pathological studies showing that humans that have had an angioplasty or a stent placed never do fully recover their endothelium. There's always some area that's not fully regenerated. Now, the vascular smooth muscle cells can transdifferentiate into something that's a little bit more like a Teflon coating, so that you can get a monolayer of cells that is less adhesive. But endothelial, after a vascular injury that we do in our patients with balloons and stents, you never get full re-endothelialization.
So that may have a real implication on antiplatelet agents or therapies afterwards, or matching elastic modulus with stents to be able to minimize some of these edge or intra-treated area effects that are going to stimulate this proliferation.
Yeah, good point.
Could you just take a moment to comment on whether there's any significance? It seemed like a lot of your work dealt with the arterial biology, and yet most of what we're focused on here is largely the venous biology and pathophysiology. Is there a difference with regard to your most recent comments, especially about re-endothelialization? Because it seemed like a lot of the research in the past there had been dealing with arterial circulation. Could you take a minute to comment on whether your data is truly something that we can extrapolate to the vein, or do we need a whole separate set of research specifically to that biology?
I think you're quite right. We need studies of CCSVI models in animals to really understand what's going on with the endothelial and vascular smooth muscle cell biology, because most of the work that I've done and others have done have been on the arterial side in terms of effects of shear stress and cyclic strain. That being said, there are some studies with human saphenous vein, but again placed into an arterial circuit. And we know that in an arterial circuit, the vein wall thickens, that the endothelial cells can be lost. You have denudation. And that contributes to the disease that occurs later on. 10 years after coronary bypass grafting, these veins become quite diseased. But that's an arterial circulation. So I think there is a deficit of information. Certainly there's a deficit of information of what's going on in the microvasculature in CCSVI.
My name is Carol Schumacher, and I want to ask about infective agents, particularly tick-borne infections like Lyme and other spirochetes, related spirochetes. And I'm wondering if I've heard investigators speak about those agents getting into the vessel walls and maybe causing trouble, increasing disturbance. And I'm wondering if you have any evidence to support that idea.
I don't have evidence, but there's quite a bit of data in the literature that suggests epidemiologically that certain viruses and pathogens may accelerate atherosclerosis. I don't know about venous disease, but there's a fair amount of epidemiologic data. Those epidemiologic data were strong enough to convince people to do trials with antibiotics. And those trials have uniformly failed to show any effect of antibiotic therapy on the progression of atherosclerosis. That being said, it doesn't mean that pathogens aren't playing a role in atherosclerosis. It just means that we don't know how to deal with that. So I hope that answers your question. But specifically, Epstein-Barr virus is one of the viruses that have been associated with endothelial dysfunction. Cytomegalovirus we've studied, CMV, is associated with endothelial dysfunction. CMV, of course, is also associated with vasculitis and progression of vascular disease. So the answer to your question is yes, the pathogens probably do play a role in progression of vascular disease.